Thank you, Giancarlo. I am sorry to be forced to substitute for my great friend Ivo, but a very serious personal reason prevented him from coming. And so how do I move the...
No, just press the... Yes.
Oh, okay. I believe you all know that the junctional zone of the myometrium was discovered in 1983 by Ricak, who found this on magnetic resonance, and the dark area here is what the original MRI from Ricak. And you also know that this zone cannot be distinguished with normal histology. So it's a feature discovered by imaging, which is, to me, something almost exceptional. Now, during pregnancy, the vascularization of the uterus, of course, not only changes, but has to be potentiated a great deal because of the function of the uterus. And so there are, after mid-pregnancy, utero-placental spiral arteries with a diameter of more than 200 microns and open every couple of square centimeters of the basal plate. And then we have the basal arterioles with a diameter of less than 120 microns, which do not open into the intervillous space of the placenta. And here you can see in red the glandular structures, and in green the microvascular structure of the superficial end of the basal endometrium. Now, what is important is to bear in mind what are the factors in vascular decidualization, and you can see here on the A microphotograph the stromal cells surrounding spiral arterioles, and in yellow are the mounting of a decidual response shown by cytoplasmic expansion and rounding of cells. In the B microphotograph, you have the perivascular uterine natural killer cells that, in spite of this terrible name, are very beneficial. They are not killers. And they secrete a variety of chemokines, cytokines, angiogenic factors, etc. So all of these things need to be borne in mind. And then it's also very important to remember the role of the trophoblast in remodeling the spiral artery by a sort of an invasion that you see here on the first trimester and here on the second trimester is expanding during pregnancy. And here is the picture, or the microphotograph of a utero-placental spiral artery at term. And at 15 weeks, you see how this process in the myometrial junctional zone starts with a swelling of smooth muscle cells, disintegration of the elastic membrane. And here is again the spiral artery at term, and in the central and paracentral zones of the placental bed, these utero-placental arteries undergo a whole series of physiological changes characterized by fibrofibrinoid remodeling. So very rapidly, we go to 4 different topics. The first is preeclampsia in the adolescent. And we have a paper presently submitted and accepted by the American Journal with 3 main points. Pregnant nulliparous adolescents are at increased risk, which is inversely proportional to their age, of major obstetrical syndromes. There is emerging evidence indicating that in addition to the well-known socio-demographic factors, there is a biological immaturity of the uterus to account for the increased risk of problems. And in most newborn, that's another relatively new concept, the endometrium is resistant, at least partially, to the action of progesterone. And it is this rate of transition from a partially resistant to a fully responsive tissue that determines the outcome of pregnancy during adolescence. And here you see that this is the normal and this is in preeclampsia. It is the biological immaturity that leads to defective deep placentation, which is the characteristic of the human species. And here is an old picture from my friend Ivo's early work, when you see that in preeclampsia there is a complete absence of physiological changes in the spiral artery in the myometrial junctional zone. And here is another way to show it in preeclampsia. As you see, the placental bed, the changes in placental bed are different than in the normal placenta. And there is another issue that is very important. What is the effect of menstruation in the very young age, right after menarche? And this study from Finland shows that ovulatory cycles increase from 49% at 1 year after menarche to 86% after 5 years. So a pregnancy very early after menarche is possible, but there are problems. And we go to the second point, which is preeclampsia no longer in adolescents, but in hypertensive women. And this also creates problems. And again, you have the difference between the normal placenta and the spiral arteries and the narrowing here during preeclampsia. And you can see that in hypertensive preeclamptic women, there is an obstructive atherosclerosis in the junctional zone, myometrium, utero-placental spiral artery, and here are 2 of the pictures that appear. Now, defective deep placentation leads to a series of problems, and in hypertensive disorders, defective deep placentation is joining forces, if you wish, with the junctional zone spiral arteries, and you can see in A here a severe spiral artery atherosclerosis under the placental infarct here, and you see the normal on the other part of the placenta with a normal utero-placental spiral artery. So we do see morphological important difference in the presence of hypertension and what we call preeclampsia. And if you look in hysterectomy specimens of uteri at term, you can see that when there is normotension, basically there are no obstructed spiral arteries. Also, in the event of chronic hypertension, but remember there are only 2 specimens here, they are not easy to come. Also, there was no sign of obstruction of the spiral arteries, which started in preeclampsia with an 8%, and finally in preeclampsia with fetal growth retardation. You see that this figure went up to 70%. And so we begin to understand some of the mechanisms underlying these processes. Moving now to preterm birth and the vascular pathology in this condition, we have here again the placental bed here on the left with the spiral artery, and the non-placental bed with all of these fine arterioles and obstructions in the chorionic membrane. And there is a sort of very fast aging that occurs in intrauterine tissues in spontaneous preterm birth and in preterm premature rupture of membrane. And Peiettini recently reviewed the literature on this phenomenon of atherosclerosis, and he concluded that although placental aging is a well-known concept, the mechanisms through which aging takes place during normal pregnancy, but even more during premature aging in adverse pregnancy outcomes, are still, unfortunately, unclear. And here are 4 pictures of acute atherosis of the basal arterioles in the placental bed and the membrane. Another 4 pictures of what has been labeled as decidual senescence, precocious if you wish, and again the physiological changes in case of acute atherosis in a decidual spiral artery. Acute atherosis of basal arterioles associated with atherosclerosis of spiral artery, utero-placental spiral arteries, as you can see, is a phenomenon that increases very much in case of a variety of conditions, whereas it's basically absent in normotensive women. In essential hypertension, you have a 20% of women affected. When you go to preeclampsia, it's 80%, and when you have essential hypertension with preeclampsia, it goes to 100%. So there are a series of progressive negative phenomena that occur depending on the type of obstetrical syndrome that we observe. And Hassan, recently reviewing a large number of placentas, found out that in normal placenta, acute atherosis is basically unknown. It goes up to 10% in the case of preeclampsia, 9% with fetal death, 2.5% in mid-trimester spontaneous abortion, 1% or 2% in case of small for gestational age babies, and 1.2% in preterm labor and premature rupture. And he concluded that acute atherosis is rare in normal pregnancy and occurs more frequently in patients with pregnancy complications, including preeclampsia, preterm rupture of the membranes, mid-trimester spontaneous abortion, fetal death, and small for gestational age babies. The lesion, he said, was more frequently observed in the decidua, whether parietalis or basalis, than in the decidual segment of the spiral arteries in those patients where a placental bed biopsy was carried out. And again, according to this work, in case of hypertension, there was a 16% of lipid infiltration, which rose to 63 in the case of preeclampsia, 46% small for gestational age, post-maturity 57%, and very interesting, in case of maternal cardiac disease, it went up to 100%, even though the small numbers will require a cautious approach to it. The last point, risk of cardiovascular diseases later in life, and these phenomena observed during pregnancy. I personally found this a fascinating topic, and we start with the idea that diffuse lipid infiltration in the placental bed, something that then occurs in case of cardiovascular disorders, again, is present in every one of the complications listed here: hypertension, preeclampsia, small for gestational age, post-maturity, and again, in case of maternal cardiac disease. So we know that. What have I done? Okay. There is accumulating evidence suggesting that women with a history of preeclampsia show a high prevalence of major cardiovascular risk factors, and therefore later in life they are at higher risk of developing cardiac problem or cardiovascular problem. Similarities between preeclampsia and atherosclerosis, as well as between acute atherosis of spiral arteries and coronary atherosclerosis, have been observed, which is now coming together of people interested in fetal-maternal medicine and people interested in cardiovascular disease. And intravascular inflammation, changes in lipid metabolism, and macrophage infiltration of the intima and media are seen in both acute atherosis and atherosclerosis. Therefore, hyperlipidemia and abnormal lipid metabolism combined with intravascular inflammation can defect endothelial cell function and may lead to atherosclerosis in non-pregnant women who have a past history of preeclampsia, because it was shown, this phenomenon, already during the pregnancy. And you can see that if the utero-placental spiral artery shows atherosclerosis in the myometrial junctional zone, then there is an increase in cardiovascular risk. If there is atherosis, on the other hand, of the basal arterioles, there is no increased cardiovascular risk. And in case of hypertension, you have an increased vascular risk, but not in case of prematurity. So you can see that we are beginning to open up new avenues for research where those people who have made their specialty to study vascular diseases and people interested in fetal-placental, in fetal-maternal medicine can and will and are joining forces. Thank you very much.